We're going to switch to the vascular portion of our meeting, and I have the opportunity to update you all on the ENRICH trial. I think most of the people in the audience are familiar with the trial. I'll do a brief introduction of it and then get down to the update. These are my disclosures, and the most important one is that NICO is funding the ENRICH trial. So the rationale for the trial is pretty clear. We've had now two big major landmark studies that have addressed both open craniotomy and minimally invasive catheter-based thrombolytic therapy that were negative, and I'll talk about those. But we really haven't changed the natural history evolution of this, and we're still not affecting the economics of the disease. And the primary causes for intracerebral hemorrhage are becoming more prevalent. We have more patients that are older with hypertension and cerebral amyloid angiopathy, and we have more anticoagulated patients than ever before. So we're just going to see more of this. The rationale for clot evacuation, in my mind, is related to these three main points. The first one is intracranial pressure control. The second one is the prevention of clot expansion. And the third one is the prevention of the secondary inflammatory cascade. And I'll touch on those 3 points very quickly. So for intracranial pressure control, this really becomes relevant for hematomas that are greater than 30 cc's, where if they don't have immediate ICP issues, they're most likely going to have them secondary to perihematomal edema. And it is important to develop a solution that deals with the mass effect as quickly as possible. Along those lines, even if we fail on improving neurological outcomes, but we are able to shorten lengths of stay without causing any detrimental effects to the patient, that would also be a pretty significant win, because half of the patients with ICH die from medically related complications in the ICU, sepsis, pneumonias, DVTs, etc. So that point is critical, and it needs to be developed. The second one is the prevention of clot expansion, and we have a lot of data that supports that being a big issue. The most notorious group for this is Javier Romero and the Mass General Neuroradiology Group, has done a lot of work on the spot sign and markers for progression. And we've seen these pictures over and over again of hematomas that maybe could be salvageable, but if we don't intervene quickly enough, they become non-salvageable. And we need to be able to get to them and identify bleeding vessels and avoid rebleeding, which was the dooming point of many trials. From all of these meta-analysis, looking at spot signs happen in about 24% of all ICH patients. So it's a large population, and these patients are not eligible for any intervention that has to do with thrombolytics. So it's a big chunk of our population. And then the third point is the prevention of secondary inflammation. We're very familiar with the biological effects of the hematoma and the initial damage. And we're also very familiar with what happens with the secondary inflammatory cascade that causes delayed perihematomal edema and intracranial hypertension. So our therapy is designed to avoid that secondary stage from developing are much needed. We understand the time course better now. We have a lot of animal model data, and we have clinical data on serum and CSF that have elucidated the timeline of the inflammatory response. We know when microglia is getting activated. We know when the T helper population cells are coming, and we're understanding that even in greater detail than ever before. And we now understand that timing is critical. So if all of these biological reasons are there, why can't we have more surgery? This is not my video. This is a YouTube video, but I love it because it demonstrates that very intuitive benefit of just decompression. And unfortunately, traditional craniotomy done in this manner did not pan out. And that was measured, of course, in the very famous STITCH trial. And we have gone over and over on the limitations and the reasons why STITCH failed, why STITCH 2 failed. But It had to do, one, with timing. The second reason was the method of choice of the responsible neurosurgeon was what was dictated in the protocol, and the variability among sites was just tremendous, and that was a problem. And I mean, this study was done 17 years ago, but no clot evacuation was reported. So we don't know if they did a good job or not. We were just looking at their neurological outcomes. MIST-3, if you're not familiar with MIST-3, that was the brainchild of Dan Halley, Mario Zuccarello, and Osama Ward. And it was the catheter-based aspiration followed by infused thrombolytics trial. That was the phase 3 trial was published in 2019. We were anxiously waiting for positive data, and unfortunately that did not pan out. There was a benefit in mortality. So you see at the top in blue, patients treated with that MIST approach versus control. So there was a survival benefit. But on the primary outcome measure, which is modified Rankin scores, there was only a 4% difference in the modified Rankin scores, which was not statistically significant. They were aiming for a 12% difference. So what they did see, which they had shown in other studies prior to this, was that there was a relationship in between clot evacuation and your likelihood of achieving a good modified Rankin score, defined as a 0 to 3. So the more clot evacuation or the less residual, the more likely you were to achieve that. And for the first time, this study gave us a surgical goal, and that surgical goal is 15 cc's of residual or less, or greater than 70% clot evacuation. So why didn't the study pan out? Unfortunately, the goal wasn't reached in all the patients. It was only reached in 59% of the patients. The timing included patients at 72 hours. So we can only hypothesize that maybe those patients that showed up late already had the secondary cascade of inflammation, and it was harder for them to overcome that despite a good, successful clearance of the hematoma. That was a big blow. But nonetheless, this result of giving us a goal has unified all of the trials, and I'll go over those in a minute. So thinking about these two major trials, this is what we are left with. We need to develop new trials for the disease and select patients better, clear that window of intervention, and use techniques and technologies that don't repeat the mistakes in the past, so we can achieve these 6 critical points: relieve the mass effect immediately, maximize clot removal, minimize our injury during the procedure, see well so we don't get rebleeding, decrease the length of stay, and hopefully decrease the overall cost to the healthcare system. So that's where MIPS became a viable alternative, in the preliminary work that was done by many people in the audience here, by folks at Cleveland Clinic, St. Louis University, and others, laid the foundation for the design of the trial. There were also several meta-analyses that around the time were coming out showing that minimally invasive techniques appear to have better chances of good outcome when compared to medical management and to conventional craniotomy options. So when we were designing the study, the guidelines that we had were the 2015 version of the ICH management guidelines. And the wording on the surgical management said it all. They said usefulness of surgery was not well established. Early evacuation was not clearly beneficial versus waiting until the patient deteriorated. And surgery should only be considered as a life-saving measure. So that's where we were. The guidelines have been updated. We have a fresh version that just came out in July of this year. You see some familiar names in there. I don't know if you can read them from the screen, but we have Steve Greenberg, we have Wendy Zia, who's one of the investigators in MIST. For neurosurgery, we have Jay Moko and Billy Mack there. We have from neurocritical care, Kevin Sheth. So lots of phenomenal folks were in the guidelines committee, and they've been recently updated. And this is the summary of the recommendations. So again, we still have class 2 or less recommendations for surgery, But the language says that, number one, the recommendations are confined to a very narrow target. So greater than 20 to 30 cc's of volume. And they say that minimally invasive evacuation can be useful to reduce mortality. So that's the MISTI mortality benefit approach there. When compared to medical management, it says that it may be reasonable to choose a minimally invasive evacuation over conventional craniotomy. So at least that's a big step forward. That may be reasonable. I'm sure it was a big source of debate, but it made it. And finally, the effectiveness of minimally invasive evacuation to improve functional outcomes is still uncertain. So it's not a no, it's an uncertain part. So they give us some room for ENRICH. And finally, of course, we need high-powered randomized trials for that. So that's where ENRICH comes in. Many of our site PIs are in the audience. We have 32 phenomenal partners in this effort. And this is our trial website if you want to learn more about it. The trial is trying to demonstrate that there's a clinical evidence of functional improvement, that this is a safe procedure, and then there's an economic benefit when compared to medical management. It's a multi-centric randomized adaptive trial comparing the surgical management done within 24 hours to the medical management. And ENRICH is the first adaptive clinical trial that has been designed with enrichment based on hemorrhage location for ICH. There is block randomization based on two locations, the anterior basal ganglia and the lobar locations. And the sample size was designed to be between 150 and 300 patients, with interim analysis starting at 150 and any 25 patients after that. For the adaptive portion of this, if you're not familiar with Bayesian statistical design, the biggest difference is how you look at Bayesian probability. And that means that when you're interpreting the concept of probability, instead of a frequency or a propensity of some phenomenon, which is what you would do in a frequentist approach in a traditional trial, you're looking at the probability being interpreted as a reasonable expectation that represents a state of knowledge. What that really means is the trial as it goes, it feeds the adaptation and it learns based on the data that we're getting. We do that using longitudinal modeling for interim decisions. So it predicts the 180-day outcome using the 90-day MRS and the baseline variables such as age, the size of the hematoma, location, etc. We had built-in rules for early success and early futility, which this did not meet. We have this endpoints. The primary one is our MRS, which is utility weighted and done at 180 days. And we want to show an improvement of at least 10% on that utility weighted MRS. We have primary safety endpoints on mortality and the delta of the hemorrhage volume between their admission scan and the 24-hour scan. And we have some primary economic outpoints that are related to quality adjusted life years. We have secondary endpoints on postoperative rebleeding, percentage of volume reduction of the hemorrhage, length of stay, both in the ICU and overall, and MRS at different time points. And when we report the results, the enrichment has an impact on the overall trial. So that means that we're using an across locations model that estimates a single parameter for the treatment effect, ignoring the location of the classification. So this across locations means that if we enrich in one location, at the end of the trial, if the trial is positive, it's positive for both locations. These are inclusion criteria, 18 to 80 years of age, volumes between 30 and 80, patients with a primary hemorrhage with a GCS of 5 through 14, treated within 24 hours and with a strong encouragement from us to be within 8 hours of last known normal with a good baseline. Our exclusion criteria are pretty common to all ICH trials. So we have no one with aneurysms, AVMs, or other vascular lesions. They have to have an NIH scale that is greater than 5. So they're symptomatic enough for us to know if we're going to make a difference. They cannot be herniating. They can have devastating intraventricular hemorrhage. They can have some, but not more than 50% of the lateral ventricles. They can be an anticoagulants that we cannot reverse, and they can have intrinsic coagulopathies from end-stage renal or liver disease. Thankfully, Andexa came out, I think it was 2019, end of 2019 or so. So all of those 10A inhibitors, Eliquis, et cetera, now are reversible, and that had a very positive impact because we see so many patients on these medications. So Andexa was a good thing for us. So this is our site activation and subject enrollment curve. We did trigger the enrichment rule at the second interim analysis. So we stopped enrolling basal ganglions and focused on enrolling lobar hemorrhages only. And that was because that gives us the best chance for achieving an overall success with the enrichment of the lobar group. But again, in the final analysis, if there is a significant benefit for surgical intervention, it applies to both locations as it was designed a priori. So this is the data from our last meeting with our DSME, which happened in January of this year. At that time, up to December, we had screened over 10,000 patients. So we're now closer to probably 11,000 patients that we have screened in the trial. The primary reason for exclusion has been volume, followed by primary vascular lesions, and then third place for age. But we have great people screening, looking. My PIs who are in the audience, please don't stop. We need to get to the finish line. We are at 296 patients out of 300. So we are very close. This is our 32 activated sites there. And I'll share a little bit of our data with you that I'm allowed to show you. So in terms of the MRS at baseline, most of our patients are within bounds of the protocol. I would say all of them, sorry. So they either have an MRS of 0 or a 1. Medical management are in blue and surgical managements are in orange. Our NIH show scale, the average is 17. So as we expected, these people are hurt by this event. They're very symptomatic. This is the population we want to explore. The average GCS for both groups is about 11, which is what we were expecting to be. And this is something that I'm really proud and thankful for. And these are the time metrics. When we started the trial, a lot of people told us that it was going to be really hard to get patients enrolled quickly. But our sites have done an amazing job. So what you're seeing is 3 plots. The left one is last known normal to randomization. The middle one is last known normal to arrival to the emergency department. And the third one on the right is timing from arrival in the emergency department to randomization. And the overall data for both groups is in gray. And our timing from arrival to the ED to randomization is 6 hours. From last known normal to randomization is 13 hours. So we're definitely within bounds with a significant number of patients being treated within 8 hours. So that is a monumental effort and something that in ICH trials had not been done before. In terms of timing to surgery, this is with 141 patients counted in. Phenomenal job too. So you'll see 3 boxes there. The orange one is last known normal to surgery. The light blue is ED to surgery. And the one that we care about is randomization to surgery. So once we've secured consent, the majority of the patients are in the operating room within an hour and a half. And that is phenomenal. So very, very grateful for that. When we look at evacuation rates and how they've become pivotal thanks to the results from MISTY, this is where things stand. So MySpace, which was the prospective registry, was about 90% clot evacuation on average. Mark Bain at the Cleveland Clinic had the best number there. It was 96% clot evacuation. So these in preliminary numbers look great. Chris Kellner is going to speak as well, but Chris has reported some amazing clot evacuation results. From one of his early papers, it was already at 88%. He keeps making that better. So we're seeing a concerted effort with good results to evacuate as much of these things as possible. And the field is busy. This is up to today, the active trials in ICH on clinicaltrials.gov. There's ENRICH at the top. There is SWITCH, which is the Swiss study using decompressive craniectomy versus medical management. So they're revisiting that. We have MIND and INVEST, which Chris will talk about using the penumbra devices. There's DIST, which is the Dutch intracerebral hemorrhage study using also the penumbra device. Then we have some other approaches there. Several of those are endoscopic. And then the last two, I think Chris will give us also a little bit of an update, are the MIRROR and the EVACUATE studies, which are using the Aurora Surgiscope device from Integra. So lots of activity. Of all of these trials, I think we're probably one of the closest to be finished. So hopefully we'll come off this list as actively recruiting within the next few weeks. And when that happens, it will be 6 months before we can deliver you some news. But that is the update on ENRICH.